So hello everyone, thanks for coming for the IPC Club session 3, and today we have a very interesting topic on the surgical site infection. So it's given by Prof Sasheela Ponnampalavanar. Prof Sasheela is a consultant in infectious diseases in University Malaya Medical Centre, and she's a professor in medicine at the University Malaya. Of course, she's a friend, and we have known each other in IPC for some time. She's a committee member of the Malaysian National Antimicrobial Resistance Committee and is involved in the development of national guidelines for infection prevention. She was awarded the 2020-2021 Fulbright Scholarship, and she was at Hopkins for that to train in infection control and epidemiology. And her main research interest is in HAI, antimicrobial stewardship, and multi-drug resistant organism. And she's also involved in several international research collaborations. So thanks, Sasheela, for agreeing to give us a talk today. And our panelist today is Ms. Po Bifong. We are colleagues in infection control at Tan Tock Seng Hospital. Ms. Bifong is a registered and she's the Deputy Director of Nursing at Tan Tock Seng Hospital. She's trained in infection prevention control and has been a practitioner since 1996 in private and restructured hospitals, mostly in Singapore. She's the nursing lead for the Department of Infection Prevention Control, Tan Tock Seng Hospital. Her main area of responsibility includes formulation of infection control policies and administration of hospital-wide infection control practices and programs. Basically, she's in charge of everything IPC in Tan Tock Seng Hospital and Novena campus. She was involved in the pandemic, almost all the pandemics that we have seen except Nipah. So maybe SARS, H1N1, impending MERS-CoV, mainly on preparedness for MERS-CoV and Ebola, and with the most recent being the protracted COVID-19 pandemic and monkeypox. She is a member of the infection control chapter of the Singapore Nursing Association, and the Society of Infectious Diseases Singapore. So I will be chairing the sessions. So for participants, doctors and nurses from Singapore, please log in with your MCR number at the bracket or nursing registration number at the bracket at the back. And for the others and everyone, please thank you and welcome. Share your screen and you can start presenting. Thank you.
Just 1 second.
So everyone, your questions, you just keep typing in the Q&A. I'll collect all the questions and then at the end, I'll post it to either the panelists or a speaker or both. Thank you. Thanks.
Okay, thank you, Carlos, for that very kind introduction, and thank you for inviting me to give this talk. So I'll be talking basically on implementation of a surgical site infection prevention bundle, practical approach. I'm sure many of y'all probably already have one, and if you have the same problem as me, it's like you could have a good bundle, but sometimes it's very difficult to implement one. So these are some of my disclosures. So as you all know, surgical procedures are meant to save lives. Unfortunately, unsafe surgery can cause significant harm to a patient, and patients develop SSI when bacteria gets into incisions made during surgery. So SSI can affect patients from both high income as well as low income countries, but unfortunately in low income countries, the SSI rates are much higher. So there was a systematic review that was published in Lancet in 2011 by WHO, showed that SSI was the commonest HAI in low middle income countries, and the incidence of SSI in low middle income countries could range from 1.2 to 23 per 100 procedures. And the pool rate was about 11.8, and this was much higher than that seen in developed countries, which was 1.2 to 5.2. And in Southeast Asia, the pooled incidence was about 7.7%. So it showed that people in low middle income countries were 3 to 5 times higher than high income countries to get SSI. And it also cost significant amount of money in high income countries. So you can only imagine how much higher it would be in low income countries. So this is the classification of SSI. So this is a cross section not a cross section, a transitional section of the skin on organ space of the abdominal wall. And SSIs can be divided into superficial incisional SSIs, deep incisional SSI, and organ space SSI. So I'm not going to go through it in detail. You can get the definitions and classification in NHS and SSI 2022, and I'm sure Singapore might also have one. We have a Malaysian manual for HCAI, which is in concordance with the NHS and SSI definition. But I think what is important to know is the duration of how long you would say someone has got, and how long the wound is attributed as an SSI because of the surgery. So for superficial skin and soft tissue infection, it is 30 days, but for deep incisional SSI and organ space infection, it is either 30 or 90 days based on the type of or site of infection. For example, an appendectomy is for 30 days, your surveillance, whereas for a breast surgery, it could go up to 90 days. So it's important to recognize which type of surgical site infection you are encountering in your center, because it influences the type of intervention strategies that you're going to put in. So this SSI prevention has been a global public health priority. In 2006, the WHO Patient Safety Department decided to focus on improving the safety of surgical care as its second global patient safety challenge. And WHO has since developed guidelines on prevention of surgical site infection. The first edition was in 2016, and very fast after that, the second edition came out in 2018. They had 29 recommendations for strategies to prevent SSI, covering about 23 topics, which involved pre, intra, and post of intervention periods. In the same year, in March 2018, EPSIC also came up with a guideline to prevent surgical site infection, and it had 20 recommendations. So when you are deciding on putting in an intervention in your hospital, it's very important to go through the journey of a patient, a surgical patient, at 3 points. One is before surgery, and I didn't put that. I pulled out. WHO has got all the different interventions in the different periods, but different time points. But I picked up the most significant one based on WHO, which at least the minimum we should have in our hospitals. So before surgery, it's to ensure patient has had a bath, no shaving of patients, if needed clipping, only use antibiotics when recommended, use chlorhexidine alcohol-based antiseptic, and surgical scrub technique of the hand is very important. During surgery, the minimum is, limit the number of people and doors being open, and to ensure the surgical equipment is sterile and maintain asepsis throughout surgery. Of course, there are other interventions, as you know, like maintaining normothermia and also controlling the sugar, also important factors that you could put in or choose to put in your prevention bundle. And of course, after surgery, do not continue antibiotics. It could contribute because it increases resistance and has not shown to improve SSI rates. Also to check wounds for infection and use standard dressing as primary wound care. So I think this is very important, the cleanliness, because we have seen many of the surgical wounds actually getting infected maybe after the patients get discharged, or well after the surgery has occurred. So it's always important to do the right thing at the right time to stop the surgical site infection. So though we have all these guidelines and they're all evidence-based, why do we still have SSI? So mainly there's a gap that exists between knowing and doing due to a few things. One is lack of understanding of the problem. For example, you do not know, or we do not know, what is the frequency or burden of SSI in our center. We probably think it's fine. Number two is lack of awareness and knowledge of what the effective SSI preventive measures should be taken. And of course, three is failure to disseminate the knowledge that we have. So lots of time you will see the knowledge is just among the infection preventionists or the ID physicians and maybe a few surgical champions, and the nurses, of course. But many, I would I'm sad to say many of our own colleagues would be clueless about the WHO surgical guidelines or the EPSIC SSI prevention guideline. Next is lack of adoption and adherence to intervention. So this, of course, is the failure to implement and use the key tools by the clinical front lines. And the other one is the lack of patient safety culture. I mean, these all seem, very simple, but in the real world, these are true challenges that we face. So what works for SSI prevention? So I think many of us know there's a technical component. These are the evidence-based SSI prevention strategies that we put into bundles, the ones that I mentioned earlier. And that is the easiest thing for us to come up with. I mean, it's a no-brainer. Let's just put it in. We know it works. But I think the most difficult component is the adaptive component. And this is the patient safety culture and a bit of the implementation part. It is knowing the science of safety and education. It also includes staff safety assessment, the involvement of leadership into these programs, learning from the defects, teamwork and communication. And these all are very important components of SSI prevention. You might have heard of CUSP. This is a comprehension unit-based program to prevent any sort of it's quite popular in US. It was developed by Johns Hopkins Hospital, Armstrong Institute, and if you have the time and you want to learn more about it, you can go to their website ahrq.gov, and I think they've got very good tools in there that includes this patient safety component. So when you have this adaptive component and technical component, this will improve the patient safety climate in the hospital, as well as improves the SSI surgical compliance and hence reduce SSI rate. And I think this is the success of a program. You need both these components. So as you can see here, there are many guidelines out there to prevent SSI or related to prevention of SSI. So, you have this is just WHO, and then you have the CDC and EPSIC ones, which I didn't include here. So we have many guidelines, but today I'll be touching on these two. One is most of my slides actually will be with reference to these two guidelines, which I think they're very useful. I'm sure many of y'all are already using it. One is the WHO Preventing Surgical Site Infection Implementation Approaches for Evidence-Based Recommendation. And the other one is Implementation Manual to Support the Prevention of Surgical Site Infection at Facility Level, Turning Recommendation into Practice. So I would strongly recommend that you have a look at these two guidelines. They're quite an interesting read, and there are many features in it. So the WHO implementation framework has got a stepwise approach to implementing any infection control program, actually. So there are 5 steps to it. The first step is preparing for action. The second one is having a baseline assessment. The third one is developing and executing the plan, evaluating the impact of your plan. And step 5 is sustaining the program over a long period of time. And embedded in this 5 cycle of implementation is multimodal strategies, which you can take consisting of elements of more than 3, usually 5, implemented in an integrated way with the aim of improving the outcome and changing behaviors. It includes tools such as bundles and checklists, and it should be developed by a multidisciplinary team that takes into account the local condition. So the 5 common components in this multimodal strategy is monitoring and feedback, reminders and communication, cultural change, system change, training and education. So this multimodal strategy is embedded in all these steps. You don't have to take all of them. Sometimes you can just take about 3 if that suits that step that you are doing. So the first step is preparing for action. And I think this is the the most important step. It is getting ready to start a program or strengthen what is already in place to improve SSI prevention in your facility. So the first thing, it involves identifying resources and measures needed to support a successful implementation for future action and starting to put them in place. So the resources, as usual, it's not only money, but human resources. Do you have enough people to run this program effectively? And do you have infrastructure in place? Like if you want to put in an SSI program, do you have enough, depending on what you want to put in, do you have the skin prep solution? Do you have enough clippers? And do you have IPC supplies? Do you need to train people? Do you need to bring in trainers? And also, how are you going to plan and coordinate these activities? It's also very important right from the start to engage and communicate and advocate your program to garner support from management and other key stakeholders, so that your program will be sustainable. And if top management supports it. And this step may take months depending on your facility, like whether you already have a program or you're just starting out. So it would take time, but I think it's worth investing your time to ensure all this is in place. The next thing in preparation of action is think about the implementation ability from the beginning. So depending on the resources you have, you can decide whether you want to start small or big. For example, you can start one procedure at a time in a stepwise manner and then expand to the whole hospital. So if you come from a big hospital like mine is a 1,600 bedded hospital, and we have many surgical units and subunits, it was impossible for us to start for the whole hospital an effective program. So we started with one surgical unit. If you come from a smaller hospital or you only have one specialty, like we have some hospitals over here that probably just see orthopedic surgeons, then it's possible to start for the whole hospital, and you have like maybe a 200 bedded hospital. So think about that. But so how do you identify, if you want to start small, how do you identify which surgery to work on? So this could be based on your risk assessment. So you always want to pick the surgical you probably want to pick the surgeries which are high volume and high risk surgeries. For example, surgery with prosthesis or cardiothoracic, they're high risk. You can't bear to even have one prosthesis infection, because it costs a lot to the patient. As you know, management always sees dollars in signs. A cardiothoracic surgery is high mortality rate, and it's a morbidity as well. The other thing that you could choose is which SSI to do is maybe the SSI that is required to be reported publicly or in your hospital that has been made a KPI. The other thing is you want to choose a surgery that has high SSI rates. So how would you know that your facility is having a high rate of a particular SSI? Well, one is if you already have an ongoing audit or surveillance system. If you don't have one, you could probably ask your surgeons. But most of the time, I can tell from my experience, when I ask my surgeons, what is your rate? They always say, oh, we don't have any infections. Our rates are very, very low compared to other hospitals. But as an ID physician, I sometimes get a lot of referrals from a certain specialty. So my gut feeling says that there's probably a lot of infection that particular surgical team, even though the team themselves feel they don't have a high rate of infection. And that's when you can start your auditing process then to see whether it's high or it's low. The next step is the formation of a multidisciplinary team. So once you've already had an idea of which team you're going to work with, and you have a plan ready, you'll form a multidisciplinary team. And it's very important that your team has representative and experts from all disciplines that the project will touch. This is to improve perioperative teamwork, communication, and a patient safety culture. And more importantly, it also ensures the support and sustainability of the project and ownership. I always believe this SSI project does not belong to the infection control department. It belongs to the individual team. So in all our SSI projects, though the infection control team kind of facilitates, but the surgeons actually lead their individual SSI projects. So we get the senior management involved, we get the surgeons, preferably a senior surgeon and who's a frontliner. So it's not one of those surgeons who are probably, don't really see patients, but probably doing a lot of admin work. They're probably out of touch, but it's good to get a senior person who's also a frontline surgeon. Nurses, you probably want to get the OT nurse and ward nurse, as well as your wound care nurse. Again, you think about the journey of your patient through the surgery and who is involved in their care. You will also get the anesthetist, the infection preventionist and pharmacist, and other related disciplines depending on what sort of intervention you want to put in. For example, probably want to get the microbiologist in, or the quality improvement people in, or patient safety person. If you have some infrastructure issues, you probably need the engineer and informatics to help you with data. And very important, you get a motivated team that believes that they want to make a change, and the SSI rate is high, and they're willing to work. So the next thing is, I think when you form your team, it's very important to also think about what are the barriers that might contribute to the failure of failure of the project right from the start, so that you can already put in mitigation measures. So this list is not exhaustive. This is some examples of what could contribute to the failure. One is, of course, lack of direct leadership involvement. So if your leadership doesn't support, it's very difficult to get a multidisciplinary team to work together, right? Also, again, making sure that every multidisciplinary team is there, making sure that you have dedicated time for training and education, you have enough cost to buy things that you want to implement. For example, in my hospital, we took out all the shavers and we changed to clippers, so we had to make sure there was money, and we needed to put in a budget for that. Poor communication. So these are some of the things that you will need to identify in your own setting. Step 2 is doing a baseline assessment of the current situation. So you want to look at the burden of SSI in your setting, as well as what are the gaps of the SSI prevention practices. So why do you need to do this? Well, this is very important. This is a very important step for to develop a tailor-made realistic action plan for your healthcare facility. It also highlights the strengths and weaknesses, risk and needs and resource gaps. And it's also important to convince these decision makers and surgical teams and other stakeholders why you need to do this project and why you need to embark on it. Because without data, no one is going to listen to you, right? So what can you do? So one is you need to gather new or review existing data on your SSI rates, and also what are the prevention practices that are currently occurring in your hospital or what you have in place. You also want to assess patient safety culture within an organization that you're in, and also identify local barriers and implementation. So how can you do it? So one, to identify the gaps, I think what we used and I thought was very useful was the EPSIC surgical assessment tool. And WHO also has infection prevention tool framework for which also has a similar question. But I thought the EPSIC was short and sweet, was just enough for a center like ours. And we did you can use this to identify what are the gaps in your setting. So for example, the general question is, do you have a surveillance which is using acceptable international methodology? What sort of operation theater do you have, and what are the primary operative measures that you have, and so on and so forth. So how do you get this information, or how do you fill up this form? Because as an infection control person, sitting outside, you wouldn't know. So that's why you have a multidisciplinary team. You speak to your team, you speak to the OT staff, to the ward nurses, the anesthetist, the surgeon, maybe you have link nurses in your OT. And also you go into observed practices like, how long are the surgeons scrubbing, or the OT staff scrubbing their hands, or sorry, doing the surgical hand prep, what sort of practices are they using for clipping or shaving, for hair management basically, and what sort of skin prep they're using. You probably will take in your audit form or your checklist to see actually what is happening. And then you need to collect the data on your SSI rates, basically data of all the patients who've gone for a surgery, see who has got an SSI, and what are the practices that is currently being done. So WHO has got a very nice SSI surveillance for peri and post-operative data collection, and also they would advise on how to continue, because it's very important that these patients are monitored till the end of the surveillance period. So it's either 30 days or 90 days. Many times surveillance are done only as inpatient surveillance. So a huge chunk of your SSI will not be captured and it will be underreported. So it's very important that you find a mechanism to complete your surveillance for 30 days or 90 days. I've not put the reference here, but Public Health England also has got a nice sort of guideline on how or a questionnaire you can use when you call up your patients and talk to them. So this surveillance or audit can be done over a 3 to 6 months period, depending on the resources that you have. You want to find out your baseline SSI rate, which you give it as per 100 operated patients in your hospital, and also compliance to the perioperative surgical procedure. So this WHO form is very comprehensive. It has all the information on the intra and post-operative strategies that we should have. And what about patient safety assessment? So again, going back to the AHRQ website, you could look for tools that you can assess patient safety assessment. So this will involve the frontline staff and leaders to identify their safety culture priority measures that need to be improved. So you will see what is your leadership response to staff patient safety concerns, communication and teamwork, learning from defects, again, just culture and being patient-centered. And they've got a nice form here, a simple one, but I would suggest that you go into the website and have a look, because they've got a very nice module that you could do. So the other thing is to also assess the barriers and identify the barriers that you might face, and mitigation tool so barriers you might face during implementation. So they also have a nice form known as the BIM tool, which is the barrier identification and mitigation tool, that to assess what is your baseline and questions to help with your implementation. So some of the questions that they focus on is healthcare worker knowledge, attitude and perception, your environmental readiness. So do you have the equipment that you need? Do you have human resources? And many other questions will be asked to help with your implementation. And also it touches on a guideline. How feasible is your guideline? How usable is your guideline? It's just not something that's put on a shelf and people can't use. It also prioritizes barriers to improve compliance in your clinical area, and it also provides a framework to develop your action plan. So I think this component is very important to also put in during your planning and your strategy. So step 3 is developing and executing an action plan. So once you've got your baseline assessment, you would feedback this assessment result to the team and key leaders, meaning your management. So you will let them know about your SSI rate, your compliance to the compliance that to the strategies to prevent surgical site infection, whether pre, intra, or post-op, and also the gaps in practice, the practices that you picked up from your maybe EPSIC assessment tool or patient safety assessment tools. Then with this multidisciplinary team, you will develop a feasible SSI prevention intervention together. So make sure everyone is involved. And this will be based on either a local guideline or international guidelines. And you want to probably develop checklists and bundles, which I think are very important to guide your plan. And it's a good form of communication as well. And what's important is you must make sure that your plan is realistic and it's priority driven, based on a multimodal strategy. So I think this is very important. And to be realistic, sometimes when we have a plan, we say, I'm going to get everything down to 0 and, I'm going to put in everything. But I think you should see what your center is capable of, you know, even if you put three good strategies in and you work on it, I can tell you, you will already bring down. It doesn't have to be very high funda and fancy and expensive. If simple strategies, you know, also work. So once you have decided on your preventive strategy, you want to probably write a project charter for your quality improvement project. So usually a project charter would involve a title, and you put in your problem statement, which would include a mission statement and your project, why is your project important. You'll also write down the roles and responsibilities of each patient. And I think this is very important to state what each person is doing, and you need to write it down clearly. So I just want to tell you, Short's ready to read this out actually, and if y'all have already heard about this story, titled "Whose Job Is It Anyway?" So there's so there were these four friends: somebody, everybody, anybody, and nobody. And there was a very important job to be done, just say this SSI project, right? And everybody was sure that somebody would do it, okay? And everybody wouldn't do it. It ended up that everybody blamed somebody when nobody did what anybody would have done. The story may be confusing, but the message is clear. No one took responsibility, so nothing got accomplished. So I think that's one thing I learned over the years as well. When you want to get a job done, it's important to identify the patient and have very clear roles and responsibility of each person. The other important thing is to also show how your progress is going to be monitored, how you're going to review your data, how you're going to report the data at meetings. Also have a timeline ready, and it should be, again, clear and realistic. Don't think you can finish everything in 3 months. It will sometimes take years to complete a project. Have key stakeholders, key stakeholders, and you should also write down how it benefits the organization. After you write down the project charter, it's very important to disseminate and seek approval of your leaders and senior facility management to ensure they have your buy-in and you have allocation of budget, resources to ensure the sustainability of your project. You should, present this project and the data you have at OT subcom, if you have an OT subcom, or your hospital infection and antibiotic committee meetings, or at your medical advisory committee meeting, and even patient safety meeting. And I must say that we presented our data and our project in every one of these meetings. So the more people know about it, there's more hype. I think there's better chance of the project being sustainable and successful. Also, budgets and other resources needed should be looked into and asked for. For example, if you need a database, if you need to put up posters, training, and purchase equipment. So this is an example of our kind of charter when we embarked on our project. So when we started our SSI prevention project, we started on ORIF, open reduction and internal fixation. So our title was prevention of SSI in ORIF. And our mission statement was to reduce SSI rates in ORIF in closed fracture by 50% within 4 months using an evidence-based bundle. And why is it important? Because we said, it causes significant morbidity and it can be reduced by evidence-based strategies. And then we also had written down clearly how we wanted to monitor our progress, like how often would we analyze our SSI rates, how often would we analyze our compliance rate, and we also wrote its benefits to the organization and other stakeholders as well as patient. We also wrote down the roles and responsibility of each person clearly, like what would management do, surgeons, infection control, crop nurse, ward nurse. So everyone had a role clearly written down, and we wrote a timeline and using a multimodal strategy. Now I'll just give you an example of what this multimodal strategy would look like. So an example scenario would be, just say your SSI cabbage rate was 30% and hair removal method used was shaving, and the team decides that, it's important to avoid hair removal before surgery procedure, or if you have to, you're going to use a clipper rather than shaving. So the first thing in your multimodal strategy will be system change, right? And here you you need to decide on what infrastructure, equipment, supplies, and other resources, including human, are required to implement the intervention so that there's consistent delivery of care and to make sure the execution of your project is easy and safe. So what you want to probably put in place or improve is a sustainable procurement system and budget to produce single-use clippers. You should also have a safe and correct disposable method for your clippers. This might seem something simple, but if you don't have one, your staff will not know what to do with those clippers. Is there a proper cleaning and decontamination of the handle? You must remember that the blades need to be thrown away and not reused. So these are the things you need to clearly state. And another thing is where the clippers are going to be kept, because they might walk away. So it's very important to know where all these things are and where you can find the clippers and where you need to buy them if the patient comes in over the weekend. It's also important to review your hospital policies and see whether it needs any change, because now you're changing your guidelines and your strategies. The next thing is training and education. So you need to decide who needs to be trained, or whether anyone needs to be trained at all, or you already have sufficient training, and what type of training would you need, and how frequently you need to do the training. Do you need any training aids, and does your facility have it? So would you be doing it virtually, or would you be doing hands-on? Will there be a competency assessment? So you need to put things down, to make sure that you have all this training equipment ready. Also, how frequently are you going to train your staff? And you have to make sure, it's all scientifically evident, because I can assure you, people will ask you that question, where did you guys get this evidence from? The next one is monitoring and feedback. So for this, you need to monitor and feedback of how you're going to monitor and feedback recommended practices and procedures, as well as available resources and supplies. How you're going to feedback that, a patient came in and we couldn't get clippers that weekend, and so the patient ended up shaving. So all these things need to be thought of. Healthcare workers' knowledge, attitude, and perception problem, timely feedback of SSI rate and risk factors of SSI, and essential step in identifying if the intervention, and this is an essential step in identifying whether the intervention that you have implemented is safe and effective, and whether you need to improve it. So for this, you probably want to put in a monitoring, reporting, and feedback system regarding the reliability of single-use clippers, the KAP of the staff, what is the adherence to the SOP, and also your SSI rate. And you should integrate the using of clippers in your pre-operative checklist and patient information leaflet. And this is important. This is an important thing as well, because sometimes we have checklists on our EMR system. The nurses go to that list. So you must remember to change that, because when we put in our clippers, for a long time, it took us to change our EMR system from shaving to clipping or no removal of hair. So communication and reminders are also very important. It's to promptly and remind healthcare workers about the importance and the relevance of the practices of prevention of SSI, especially at the point of care. It's also important to advise patients and their visitors on the standard care in your hospital. This is what we do right now, because even after we change to clippers, especially in a more traditional culture like ours, a lot of patients would rather rather remove their hair at home rather than in hospital, and they end up shaving because they do not know the hospital procedure. So we should make sure that all this is thought of, how we're going to educate our patient. Also, senior leaders and decision makers should constantly be remembered and assured that what you're doing is right and it's effective. So, you could have posters and patient information leaflets put up in strategic places. The next thing is safety, climate, and culture change. So it's important to create an environment and perception that that facilitate its commitment to SSI prevention at all levels in the facility. So senior management is, going to raise funds for equipment and resources and champion the IPC activity, individual level and teams. You must make sure there's accountability and ownership within the team as well. And for that, as mentioned earlier, it's important that the team co-develops the intervention, and it's not forced to follow whatever one person says. I think this is very important. It may take it may take a longer time to come up with the intervention, to get many people involved, because not everyone is free at the same time. But in the long run, this is more effective. So, what you might need to do is you should try to able to convince your management that clippers definitely is the way to go about things, engaging your surgeons and nurses on the awareness. So, for example, we started, this clipping in the ward, but then sometimes the hair removal is done in OT, and the OT nurse may not know about it. So we should make sure like everyone knows about what's happening. We can have focus group discussions and other ways of communication. So the next thing is assessing the impact, which is step 4. So you'll conduct a follow-up assessment using the same tool as we did in step 2, which is your WHO surveillance tool. And this is crucial to determine the effectiveness of your plan within a defined period of timeline. So you want to determine what has worked, what has not worked, and what are the remaining gaps that you need to fill, because you might need to do it as a PDA cycle, because one method may not be effective enough, or someone has left the hospital, a key person, and now you need to retrain another person. So sometimes things change. You need to evaluate your intervention, so you need to focus on the impact and acceptability, and if possible, plan a cost effectiveness or cost benefit study. Cost effectiveness is good because patients can also give their feedback. And outcome measures, you will again look at the SSI rate in compliance to the processes. So assessing the impact, again, how would you analyze the data? So you should have a regular schedule to evaluate you should have a clear auditing methodology put in. Usually the rates are plotted in a statistical process control chart, a run chart at regular frequency. You can do it weekly or monthly depending on your resources to measure the performance, and this should be fed back. So the next one is communication, and which is very vital, with the team. So you should have a schedule on how you're going to, how frequently you're going to have a meeting. So in our case, the leader, which is the surgeon, will always say, okay, we're going to meet up in 1 month's time, and we already put it in our calendar and we're ready for it. So for the sustainability of the project, I think, this is the final phase. All key stakeholders, the frontliners and your team members and management needs to see that this is successful and how you're going to roll out to the whole hospital. You maybe now want to put it on EMR and make it a standard of care for everybody and make it a key performance index. Key performance indicator. And I think one of the important things is to build on the momentum of your work. Always celebrate your successes and maintain engagement with your team. So I'm just going to wrap it up fast so you can go and look at this paper. This is a multimodal strategy, basically done by the WHO team in Africa in about 5 hospitals. They used a multimodal strategy, and it showed significant reduction in their SSI rate, and also in the compliance of the basic bundles that they had put in. And also it has shown to be, it improved SSI rates in colorectal surgery, in LSCS as well. This is our study when we embarked on this SSI prevention initiative. We started off with our ORIF, as I told you before. We came up with a checklist, and we emphasized on documentation, and we put in the dedicated person who's going to fill that up. We used the method that I mentioned earlier, a multidisciplinary team, meetings, communication, collecting of data and feeding back again. And we showed a significant reduction. This is just pre-intervention was 3 months, post-intervention was 4 months, and we already saw a significant reduction in our SSI rates. And we saw an improvement in our compliance to the documentation of the different strategies. And I can tell you, this was not rocket science. I think how it worked was, it was good communication between the team, and everyone wanted to make a difference. So since then, we have rolled out the SSI prevention bundle to mastectomy, which was in July 2019, cardiothoracic March 2019, neurosurgery in October 2020, LSCS in 2020. And you can see we had shown a reduction of 23% in mastectomy, cardiothoracic 6%, neurosurgery 48%, ORIF since our 2018, we have brought down the rates to by 74% and LSCS 65%. I'm not going to tell you what it was before. It will be quite shocking for some of them, but I can say many of them are now leading towards less than 5% or even lower. So what works in preventing SSI, prevention or in any sort of prevention is an SSI surveillance and timely feedback of results is 1, and 2, implementation of a multimodal prevention strategy using evidence-based intervention decided by the team, all right, plus a patient safety culture improvement, so teamwork, good communication, staff engagement, leadership, and learning from defects. And when we and I can't emphasize enough on a multidisciplinary team, and it's very important to say in the multidisciplinary team, everyone is equal and everyone brings their expertise to the table. So a surgeon or is the same as an infection control nurse or even a cleaner that sometimes joins our meetings as well. So with that, I thank you. I'm sorry if I took too much of time.
No, it's okay. I think it was very interesting, especially the last part on your personal experience. The entire talk was very interesting. Thank you.
Yeah.
So I'll just share one of the slides for the next session promotion while the questions are ongoing, if you don't mind. Okay, so Sasheela, I have to tell there is a compliment in the chat from Prof Siva. So Prof Siva actually had said that Prof Sasheela and team had done a great job in reducing SSI significantly in cardiothoracic surgery patients in University Malaya.
Yeah.
And I strongly recommend for teams to have a good team MDT-based management in tackling this and coming up with a protocol, just a feedback. So I think nothing better than feedback from a surgeon about how IPC is doing in SSI. So that's great. Congrats. And it was an excellent presentation. And thank you for making time while participating in a conference at the back. I would just like to highlight the next session is by Associate Professor Andrew Stewartson from Monash University, and he's going to tackle quite a controversial topic since COVID, ABCs of AGPs. And Andrew usually gives excellent presentations, and I hope you all will attend. And Ms. Fu Miaoling, our nursing lead from Khoo Teck Puat Hospital in Singapore, will be the panelist. And it will be chaired by Associate Professor Sharmila Sengupta from Amrita Hospital in India. All right. Thank you so much, everyone, for attending this session. See you all in next month.